Hello, friends, and welcome to another episode of the Concussion Nerds Podcast. And today we're going to be talking about common pitfalls that I see in the concussion space a lot, which are why our clients get stuck and aren't progressing. We're going to talk about some workarounds and some fixes, I guess, to that. But first, if you haven't already joined our Rethink Rehab workshop, this is our foundational 4-hour workshop for clinicians who are ready to step into a place of increased confidence and understanding in knowing how to do an integrated multi-systems approach to working with complex concussion. We are teaching it live for the last time until some point this fall, June 27th, 9 a.m. Pacific time. We're doing special pricing for this month because it is the last time we're teaching it live anytime soon. So jump in, link is below, come check us out. Also, side note, I just have to my son was watching YouTube and he was watching the greatest vocals of I think it was Britain's Got Talent. And sometimes, I've like to think I'm not alone in this. Sometimes some things just overtake you and emotion just bubbles. I was literally in my kitchen doing meal prep today and Hudson's watching the show and I just had to stop everything that I was doing. And I walked into the living room and I watched, he's got it on the TV, and this woman just singing with so much heart and so much soul. I'm sitting there and next thing I know, goodness gracious, tears start coming to my eyes. They start running down my cheeks. And my son looks at me, Hudson looks at me and goes, "Are you okay?" And I was like, "Yeah, dude." I said, "I'm great." I said, "This woman is phenomenal." I said, "I don't know if it's ever happened to you, but sometimes things just hit you right in the heart and you don't understand where emotion comes from, but it's just there." And oh my gosh, this woman, I don't even know what her name was. This woman's voice just hit me in all the feels and it was absolutely stunning. So anyways, just sharing that little tidbit. Back to today's episode of the common pitfalls that I see. And I see these a lot. So I see it when I mentor sometimes. I see it when I'm a therapist that gets asked for a second opinion. I see it when I do consults. And so I'm going to talk about 2 to maybe 3 things that I see. So number 1, I'm going to talk about the one that you guys hear me talk about all the time. I kind of preach it like a broken record. I talk about it on all my reels on Instagram. So we're not going to spend a ton of time on this one today, but I got to say it. Number 1, your client or your patient, depending on how you refer to them, does not have the capacity for the work you're trying to do. And if they don't have the capacity to integrate the rehab you're doing, even if it's the rehab that they do need, if they don't have the capacity to be there, be present, focus on it, and integrate it, it's not going to happen. It's not going to work. What do I mean by this? This could be the person that has overwhelming stress in their lives. Their mindset is in a really hard place. They're not sleeping well. They have multiple factors at home that they're trying to be present for. They're already seeing 2 or 3 other therapies, and you're just another thing in the noise. I did a reel sometimes healing isn't about adding more. It's about adding the right thing. And I think sometimes we get stuck in this loop, both as clinicians and for those of you on a healing journey. Unfortunately, the aspect of time is real, right? As in, these things take time to heal from. We want to give the right tools in the process of time, but it does take time. And we are an impatient population, right? We're an impatient species. And a lot of us want things done now. I fall into that category as well. And so when we know we need vestibular rehab and we know we want nervous system work and we know we want to be doing a return to work and we know we want to do all the things, we start to try to pile them all onto our plate at once. And so we're going to differentiate this. If your nervous system doesn't have the capacity, then we have a problem. So now let's actually take capacity for a second. And let's look at capacity in terms of what we think we can handle as a human and what our nervous system's capacity actually is. When I sit here and I say that, are you nodding your head in agreement? Or are you saying, Natasha, what the fuck are you talking about? Right? So, as a human, the capacity we think we have could be significantly more than what our nervous system actually means. And so, what I mean by this is the person who might be in a return to work and a mother and also still trying to do 3 therapies a week and plan a family vacation. And logistically, they're managing it. Now, they might not feel great and they might be crashing, but logistically, they're going, yeah, I can do this. I can fit it all in. But I want to pause for a second and let's look at what the nervous system is doing. So by doing all of those things, are you constantly in a place of anxiety? Are you constantly in a place of agitation? Are you constantly in a place of irritability? Are you constantly crashing? Are you dreading showing up for some of these things each day? Right? There's a difference between what we logistically think we can have capacity for versus what our nervous system actually has capacity for. Let me give you a personal example, completely non-concussion related. So for the clinicians listening, this applies to you too, right? So personal example from my life, I always said, I feel like I just finished a 4-month sprint. Okay. Logistically, I booked myself full. I had extra intensives, more than I normally treat. I had speaking gigs. I was teaching workshops. There was a whole bunch of stuff on my plate, and time-wise, absolutely, I had it. I also knew when my end date was. So when you have an end goal and you can see that target end date, sometimes you find adrenaline and energy that you didn't know you had. Now, when that end date hit, it's like my body knew because I crashed. For a good 7 days after, I barely opened my laptop. I barely thought about work. I disconnected from my clinic. I took a couple days out of town to disappear for a little bit to do some extra grounding. Because although logistically I had the space and the capacity to do the calls, to do the meetings, to do the intensives, my nervous system had nothing left. And I needed to give myself some self-love. So, pitfall number 1 is that even though the work we do might be what our client needs, they do not have the capacity in that moment to focus and integrate it into their system. And so sometimes we have to take a pause and work together as a team to figure out how do we increase the client's capacity if the work we're doing isn't actually helping to do that, but instead having the opposite effect. Pitfall number 1. Pitfall number 2. We try to do too much too soon. I think sometimes there's this internal argument as therapists that if our clients aren't progressing at a certain speed or we can't change something every single week, something is wrong. Or we need to layer all these different pieces on and we can't just stick with the same thing for a little while. And we need to remember that neuroplasticity takes repetition. It takes intensity, right? We don't do something once and it's integrated into our body and learned. And so often, sometimes we think we need to completely change and rework an exercise to something completely new instead of just tweaking or layering or modifying an exercise just a little bit, right? Let's give an example. Let's give it a kind of an easy one. Let's take the topic of balance for a second. Okay, so we know that balance is commonly affected after concussion. We also know, if we're clinicians listening to this, that the best test does not do a good job sensitivity-wise to monitor progression of balance after 72 hours of acute concussion, right? So when someone comes to work with us at Symphony, we always assess balance. We do it on a force plate. So we can see how much they sway and what their sway patterns are and the total amount of sway they have in the testing condition. From pre to post, whether that be our local clients that have a bit of a longer treatment plan in a mini intensive format, or whether that's the intensive clients that fly in and come work with me in the week. From pre to post, I promise you, their balance scores always improve. Always. I can also tell you that we very rarely, if ever, do an actual what you would consider balance exercise. Because here's my thought. So commonly people will give patients exercises that they say, okay, your balance isn't great, so let's practice standing in a corner, feet together between a wall, so you can just practice balance. And here's why I struggle with that. Because balance is the integration of at least 3 different systems. And I'll layer something else here in a second too. 3 different systems: your visual system, your vestibular system, your somatosensory system. Okay. Different conditions. By conditions, for those on a healing journey, I'm talking about if you're on a firm surface or a foam surface where your eyes are open or your eyes are closed, put greater demand on certain systems over another. Okay. So for example, if your eyes are closed, you're on a firm surface, we're putting extra demand on our somatosensory system. If you're on foam and your eyes are open, we're drawing extra on our visual system, sort of thing. My thought process is, when you see someone with poor balance, the traditional physical therapy thought process is, let's practice balance. And these are exercises people get given. So they get put in a corner, feet together or tandem, so heel to toe, and they just have to practice. And they get the corners to have feedback so they don't fall over. But again, my issue is that balance is made up of 3 different systems, the integration of 3 different systems. And so if we are just training that poor balance condition, are you actually training and rehabbing, or are you training a compensation so they don't fall and training them to bring in more cognitive control into balance? Right? So as therapists, we always want to practice this. We have this instinct that we want to practice the bigger thing or practice the bigger functional activity. But what if instead, which is what we do in my clinic and what I mentor in Nerds, is that if you assess somebody and you find they have pretty terrible balance, wouldn't a logical next step be to then look at each of the individual systems that are involved in balance and assess those? And see how each of those systems and their components are showing up or not showing up. Because if they're not showing up, how can they integrate into the task of balance then? Right? I see so often that we get in this mindset of, let's practice the thing that's not working, which is usually like a bigger functional thing, because that's a lot of what's assessed, instead of, let's take the functional thing and let's pull it back. Or if that's not working, or we're bored of watching you fail at it, let's just change it and do something different. And so I'm going to say one of the big pitfalls I see is that we're trying to do too much, or we're trying to go too big, or we're trying to bring too many systems in at once before we have a solid foundation. That is pitfall number 2. Pitfall number 3 is just going to piggyback on pitfall number 2. Pitfall number 3 is that we just keep getting people to do more of the same thing and ultimately habituate to them. So let's use exercise, for example, right? So exercise intolerance or exercise. The standard sentence that individuals with persistent concussion get given is, we want you moving your body, which we absolutely do. Go for a walk for 15 minutes a day or 20 minutes a day. If you like swimming, go for a swim. You got symptoms at 5 minutes? Okay, let's just scale back and let's just do 4. And then once 4 is good, then we can increase it to 5, and then we can increase it to 6. You love a swimmer, you want to be in the pool, or you went swimming, symptoms came on at 5 minutes. Okay, let's scale it back. And once that's good, then let's increase it. Right? So we have people just going to do the thing that makes them symptomatic. Honestly, this is the same pitfall. I'm just using it in a different example because it comes up in the concept of exercise intolerance a lot. So when it comes to exercise intolerance, I always say to my clients and to the clinicians that I mentor, you need to ensure that as much as you can from an exercise and tolerance capacity, are you actually testing the physiological piece or are you testing other pieces? So what do I mean by this? There's a reason for us that we commonly do our exercise and tolerance testing on a stationary bike. It's because we can pretty much isolate out for visual, vestibular, or cervical and really push that aerobic piece. Now, if we know that our individual doesn't have vestibular, visual, or cervical components, then we can go push them on a treadmill. But often, if your client has these other systems that are part of it, and we try and just push them into activity, is it the activity or is it the other things? So let's talk about two examples for a second. So I had a young man. He was a hockey player, junior hockey player, and he was working mostly with his athletic therapist. And then what would happen is with this team, if the athletic therapist needed an assistance or they were getting stuck, the boys would come down and work with me. I was an hour and a half south, so I wasn't the most convenient therapist for them to come work with. But what had happened is he was getting back to play and he was doing great, but he was getting a headache pretty consistently at what seemed to be a specific heart rate when he was on the ice at a certain point in the game. And so they were treating him like exercise intolerance, but it was not improving. And so I had him come down and I popped him onto a different setup and I pushed his heart rate, and we could push that boy from an exercise intolerance capacity with no symptoms. None. Wasn't his heart rate. It wasn't the fact that his heart rate was getting up that was causing symptoms. So then we had to take a step back and go, okay, what else is happening at this point in the game? Well, let's look at the posture you're in. Right? When you think of a hockey player, how much neck extension are they in a lot of, right? So he's in sustained neck extension and a lot of neck movement and balance and all these pieces. So for this young man, what we actually discovered was for him, it wasn't exercise intolerance. You could have kept pushing that poor boy and keeping him off the ice for that long, trying to improve this exercise intolerance. But when we dug deeper, we learned that it was actually a lot of his neck and some specific ocular motor function as well. And when we could treat those two pieces, guess what didn't happen in practices anymore? Right? Let's take a swimmer, right? So things are going pretty good in rehab. You know, they're doing really well with their exercise and they want to go try swimming. And you say, okay. And so they go and they do the breaststroke. And they last about 10 minutes and then they start getting this headache. And some of their other symptoms start kicking back. Is it exercise intolerance or do we pause? And again, we look at, okay, the task of swimming. What is involved in the task of swimming? What things do we need to be able to do repetitively in swimming on repeat? Makes no sense. Looking at things like neck movement, both rotations, knowing where we are, breath and breathing, right? Are they able to take that breath and hold that breath and not have intolerance to that carbon dioxide, right? So we always want to come back to look at the thing and break down the thing. And so this is where I see people get stuck so often too. And they get stuck in there, what they think is exercise intolerance. When many times, not all the time, we'll talk about if it is like we're getting kind of stuck at this heart rate, but when many times for that individual, we have to actually still address something that's been unaddressed that's in this bigger task of whatever it is you're having them doing for the exercise intolerance component. Now, there are people that I have that have honestly just gotten stuck. And so a lot of the research, if not all of the research, when you look at aerobic testing and aerobic exercise after concussion is on steady state aerobic exercise, right? So you're getting your heart rate up and then you're consistently staying in that heart rate for 20 to 25 minutes with a warm up and a cool down on each side. That's all the research. When I find that my clients are getting really stuck and we can't get past that, like, I don't know, whatever, let's say 15 minutes of steady state, I will switch out of a steady state model and I will switch into an interval format instead. I have yet to read a research paper that looks at interval aerobic training on persistent concussion. So if you know of one and I just haven't found it yet, please send it my way. If anyone wants to do a study on it, even better. But I will switch my clients to an interval fashion. And so an interval fashion ultimately means is we will still find that target heart rate that we're working at, and we will go up to that target heart rate for whatever interval we do, say 30 seconds to start. And then we will rest with a walking interval or a slow pedal or something in between for a minute. Then we will get up to that heart rate again for 30 seconds. Then we will come down to a minute, or 1 minute on, 2 minutes off. So basically for me, again, because I have yet to read a study about this, I start my clients at a 1-to-2 ratio, which means they have twice as much rest for whatever the duration of the time was that we got their heart rate up to their working level. And if we can just do 30 minutes of intervals, then I will start to either decrease the ratio or increase the intensity. And I usually start by increasing the intensity, and then I will start to shrink the ratios a bit too. So what I do find with my people that are getting stuck in that true exercise intolerance capacity sometimes is that switching to an interval training fashion, it's something different. They look forward to doing it again. It gives them a different feeling. They can have success in a different way. And it starts to build that capacity and kind of gets us over that hump that we might get stuck on. So those are 3 kind of areas that I see as a clinician and clients that I consult with, that I help treat with, that I do intensives with, that I commonly see over and over again that people are getting stuck on. And so if you are someone who's working with a client and you feel like you're kind of hit a plateau and you're at the point of your reaching spaghetti on the wall, just take a pause and think about if any of these 3 things we talked about today make sense for you and how you're approaching your persistent concussion client. And if you really are looking for a framework to know how to structure your treatments, to know where to focus, to have the biggest change sooner, then jump below and come sign up for the Rethink Rehab workshop. Or if you really want and you're ready to deep dive and have mentorship, come right into Nerds. Our doors are always open, and we are always here to support the amazing clinicians doing the work here to change people's lives. So until next week, my friends, have an amazing day. That's today's episode. Thank you so much for tuning in. If you liked what you heard, give us a like, give us a share, give us a tag on Instagram, and please never hesitate to reach out. We love communicating and connecting with you. Until next week, my friends, have a marvelous day.